Welcome to this episode of the Clinical Podcast Series brought to you by the American Academy of Optometry Foundation. On today's episode, we will be discussing the article entitled, "Is it safe to omit the 1-week post-operative examination after uncomplicated phacoemulsification?" published in our Academy's journal, Optometry and Vision Science in 2023. I'm Dr. Kelsy Steele, your host and the topical editor of the anterior segment disease care section. I'm thrilled to be joined today by our topical expert, Dr. Trevor Fosso. Welcome.
Thank you.
Dr. Fosso is a residency-trained optometrist, the director of contact lens services at Pinecone Vision Center in Sartell, Minnesota. Dr. Fosso is a fellow of our Academy and of the Scleral Lens Education Society. Thanks for being here today, Dr. Fosso.
Thank you for having me. I'm happy to join you.
Yeah, wonderful. So to get started, what was the purpose of the study, and what did they say prompted its development?
Yeah, so really this study looked to evaluate the kind of rate of complications after uncomplicated cataract surgery, specifically 1 week. So, looking at patients where if they seen at 1 day didn't have any complications, what was the rate at which a week out did they have some type of a complication? And they really wanted to look at that to see, hey, does it make sense that can we potentially cut off that 1 week post-op? Why do we need it or not? Mm-hmm. And the reason we kind of looked at, or the reason they looked into this study in the first place is just, as cataract surgery, the incidence of it is just increasing. It is the most common ophthalmic surgery done in the United States, right, making up about 50% of ophthalmic surgeries just in the US. And how often we're doing it is just increasing significantly. And right, so they're trying to figure out what's the medical necessity behind the traditional, like 1 day, 1 week, 1 month post-op period, to see like, hey, what's the reasoning behind that? And is there any way to cut back on that? Just because we know as providers, the burden on us as well as our patients, we just don't always have time for some of these appointments, for the amount of patients being seen, and everything like that. Is there a way to cut down on that and cut down on appointments for our patients to save them time and just be more efficient, and everything like that?
Right. Yeah, we know, we have this aging population and we don't necessarily have the workforce to meet that need. So yeah, great reason to look at it. So what did they find?
So what the study did, so they reviewed the records, looking at patients, kind of studied from 2019 or from February 2019 to 2020. They looked at one surgeon's records, and really what they found is, if they omitted that 1 week post-op, or at that 1 week post-op, the rate of complication that they were finding was anywhere from about 4.5 up to about 15 or 16% of patients ended up developing some type of complication at that appointment that otherwise wasn't seen at the 1 day post-op. So there was a statistically significant or kind of a significant amount of potential complications seen at that appointment.
Can you review some of the most common post-operative complications that might be expected at the 1 week post-op? So what exactly are we looking for? What were they looking for?
Yeah. So I think the post-op complications that they at least found the most of, there was really, I think there was just like 4 of them that they found. There was central stromal corneal edema, which that made up most of them. They found, so they had, I think it was 74 patients that they looked at, after they kind of whittled down all their patients, looking at the exclusion criteria. They had 74 patients who kind of met the criteria for this review in this study. Okay. And out of those, there was, I think it was 11 who had some type of a complication. Yeah. Of those, 8 had some type of central corneal edema 1 week that wasn't there at the 1 day post-op. There was one patient who had microcystic edema, so just, a little bit kind of different edema there, but some type of edema. Mm-hmm. One patient had low eye pressure, below 6, and another patient had higher eye pressure above 30, that again, otherwise wasn't noted at the 1 day post-op with those patients. But typically, the 1 week post-op, I feel the main thing we really want to watch out for, while these were the complications they were seeing and watching for, one of the big ones we always want to watch for is endophthalmitis. Is kind of the big thing we're looking for. And with endophthalmitis, they didn't have any incidents of that. And that typically kind of, peaks somewhere around like 4 to 7 days.
Yeah.
3 or 4 to 7 days is kind of common, which is why we've had that 1 week in there.
Right.
But they did note, and kind of make, they at least, talked about this in the study, saying like, if you do have a patient with endophthalmitis, like you're never going to find those patients on a routine follow-up anyway.
Right. Yeah.
Like if you
That's
have like a
good point.
routine, like 1 week
They're
follow-up,
going to have
like,
a problem.
yeah, they're never going to be like, oh, I just happened to stumble across endophthalmitis. That's
Right.
never going to happen because the patient's already calling you saying, my eye's in severe pain and I can't see anything.
Yeah.
Like they're usually coming in earlier and they're coming in an emergent case or an urgent
Right.
case, being like, hey, something's wrong. So like, at least from something like that is, a sight and eye threatening kind of condition, like you're not going to miss it because the patient's usually going to come and find you anyway.
Right.
So,
yeah. So other people have looked at this before. So how do the results from this study align with some previous similar studies as far as complication rates and things that they found?
So there's a couple of different kind of studies that they also mentioned in here as well. One was a study from 2001 where they were looking at a complication rates at that post-op week 1, and they found them to be about 4.1%, but they didn't eliminate any uncomplicated surgeries. So that was just of all surgeries. So both complicated and uncomplicated, no matter how they were looking on day 1, at week 1, there was about 4%. But you can account like, hey, that was probably about 50% of them were uncomplicated. So it'd maybe be about a 2% rate. So fairly low. But it's also important to know, like, hey, that study's from 2001. How we do cataract surgery, the technology that's available, it's very, very different.
Yeah.
Typically, the surgery nowadays, the techniques nowadays, we've learned a lot. The surgeons have learned a lot over that time period to just perfect and improve those techniques to get better outcomes and less complications too. Yeah. Other studies, there's some other reviews that they've done. There's not a lot of studies specifically looking at complication rates at 1 week out, but a lot of reviews kind of looking at these, especially at 1 day, 1 week, and 1 month. There was a review in 2015. They did a nice literature review looking at 3 randomized control trials, which are always nice to look at. And they compared the outcomes of patients evaluated at post-op day 1. So if you're looking at them 1 day versus waiting and looking at them 2 weeks after surgery. So omitting, a post-op day 1 versus week 1 and waiting until week 2. And really what they found is there was really no statistically significant difference, and it wasn't unsafe to wait 2 weeks to even see your patient. So you could potentially, they found like, hey, it was actually safe and fine to skip 1 day, 1 week, and wait 2 weeks out to see these patients. And it didn't really change the outcomes. So in 2019, there was another review of about 44 studies. And again, it didn't really support the evidence of the necessity of the day 1. It didn't really change the long-term outcome of things. But that's at least looking at day 1, not necessarily week 1. But you can kind of extrapolate it a little bit to say like, looking at it that early on doesn't change the long-term outcome for these patients.
Yeah.
So.
Okay. So they talked about, if we are limiting this, what is some other way that we can potentially catch some issues? And they did talk a little bit about telemedicine. Is that something that you use or have utilized in practice, or do you see a place where you could potentially utilize it?
Yeah. So in our practice, we have not utilized telemedicine much thus far. We've actually been talking about it more recently in terms of incorporating it. Primarily just because of, and I think this goes along with that increased burden on the providers with all these patients. Yeah. The number of callbacks we get from patients in terms of like taking time to answer their questions and things like that, having these appointment types where it's like, it might take, 3 or 4 weeks to get a patient scheduled with me, whereas I could do a telemedicine appointment and talk with them and kind of fix some of that. So that's something, like I said, we haven't incorporated it yet. I know a lot of offices have started doing it for that purpose. We're looking at adding it, but I think this could be a really good point to add that in there. Could be a good way to utilize it. I think the main reason to utilize it in post-op patients is, one, following up, kind of seeing like, hey, how's your vision doing? It's almost that the idea of the hand holding that we do with these patients, you know, like that's almost part of the big reason we have a week one is to say like, hey, how are you doing? Kind of following closely, make sure
How are you using
everything.
your drops? What drops are you doing?
Exactly.
Getting them in.
And that's the other big part is, hey, how are you doing your drops? How are the drops going? Typically at 1 week out from surgery, we're going to be adjusting their drops. And that can get so confusing because depending on, you know, at least for me, you know, we have potentially 4 different surgery groups that we refer to.
Right.
Each one of them, their drop regimen is different. And depending on what style of surgery a patient gets, within that office, the drop regimen could be different, whether they're using a combination drop, if they're using the
Or
traditional all
dropless.
3 drops, or dropless surgery. All these different options that, you know, it's just being able to review with them, like, all right, yep, here's your drops. Now we're at 1 week out. Here's how I want you to change them. Granted, a lot of offices do just print off like a schedule and say like, hey, here's your check mark. Here's your calendar for the next month. Just check the box every time you do it. But it's good to at least touch base with these patients to make sure they aren't missing something like that. And I think that's where this, you know, telemedicine in a situation like this could play a big role and be very helpful in those cases, just to kind of touch base, make sure they're doing okay, they're coming along fine. And it's more for like a peace of mind aspect of it.
Yeah, literature supports that, you know, patients do better with education from their doctor if it's given to them both written and verbally. So that might be a good way to incorporate that. So before we, you know, jump to altering our post-op follow-up schedules, what were some of the limitations of the study? You did kind of mention exclusion and inclusion criteria. What were some of the issues that we might use to make it maybe not so generalizable?
Sure. Yeah. So the study itself, it is a fairly small sample size. So there's 72 patients. But to start off with, they were actually looking at, I think it was like 506 patients initially that had cataract surgery.
Where'd they all go?
With this single provider. Well, what is that? It's like 84% of them were excluded, which means like, you know, that's the vast majority, you know, what is that? Like, that's you know, 85% of your patients got excluded. So you're only looking at 15% of patients. Of those 15%, here's where they kind of fell in. It was also done, you know, it was reviewing at a single site in Chicago. So it was primarily African-American population, urban population, and it only looked at one surgeon. You know, different surgeons, depending on how long they've been out, everything like that can make a big difference. You know, I kind of also wondered too, you know, it's like, the style of surgery that you're doing, you know, again, you know, we've got, you know, 4 different offices that we work at. Some do femtosecond assisted surgery, some do not. The difference between those two, they're, you know, like I can tell you which ones I see more edema on, and it's not the femtosecond one. So if someone's using that technology versus not using it, I'm going to see a higher complication rate. Surgeons who have been out longer versus brand new ones, like, you know, they just have more experience, things like that. But I was also wondering, you know, just when they're, you know, in reviewing this, like when they reviewed these charts, who's doing the post-op appointments? Was it the surgeon doing the post-op appointments, or was it someone else? Was it the same person doing all the post-op appointments? How are they, you know, because like I said, the main complication they saw at week 1 was corneal edema. How are they measuring that corneal edema? Were they measuring it with pachymetry, or were they just doing a slit lamp exam and say like, oh, I see some corneal edema? Well, your tolerance for assessing corneal edema could be different than mine. Like there's some difference there. And then also what determines whether or not someone treated corneal edema? You know, of the 8 who had corneal edema, 5 didn't get any treatment. 3 were prescribed hypotonic ointment. Why were they prescribed hypotonic ointment and the other 5 weren't? You know, so kind of some questions there, like, you know, I think they, you know, like, I think this is a great question in terms of like, hey, can we have this appointment or not? I think it leads to a bigger, probably better question of like, what should be like our standard post-op care? You know, what should be like the standard of care there? But I think that like, that gets kind of tricky too, because you know, and I guess kind of getting into, you know, what will be your last question of like, should we change anything on this? I don't think
that's my last question. Should we implement any changes based on the findings?
Yeah, and I don't think the study tells us we should change anything,
Mhm.
but I don't think the study tells you you shouldn't change
Right.
anything.
Yeah.
I don't think it gives you enough evidence to say like, hey, it's not right to change it
Mhm.
either. And
Right.
again, I look at part of what determines these post-op schedules is the surgeon too. So again, our office, we work with 4 different surgery offices,
Yeah.
kind of depending on what someone wants, where they're living at. We're in central Minnesota, so we've got, different areas we can go to. We can go to the
Right.
city.
North,
We've
south,
got
east,
local
west. Yeah.
surgeons. We've got, if they live one direction, they want to go this way.
Mhm.
Well, each of them does surgery a little different. One office, they do day after, where they do, maybe Wednesday right eye, Thursday left eye. We see them Friday. They do them sequential
Yeah.
day apart with both eyes. And they essentially see them for the one day of the first eye, and then we see them for the one day and the 2 day of the first and second.
Okay.
And
Yeah.
we see him at 1 week and 1 month.
Mhm.
Another surgeon we work with, he does surgery. We see them one day. He does surgery a week later. We see him one day, and then we see him 3 weeks after that. So it's a 3 week and a 1 month appointment. We don't see them at 1 week in between, except for the 1 week of the first eye. Others do one day, 1 week, and then surgeries 2 weeks apart, and others do one day, 1 week, surgeries 1 month apart.
Yeah.
There's such a huge variety there just among the
Right.
surgeons.
Seems like a lot to keep track of.
Yeah, it's hard to come up with all right, here's the standard protocol because the surgeons don't have a standard
Right.
protocol. They all do it kind of their own way, depending on how they feel like doing it, too. So yeah, and like I said, in some of these cases, we see them at the 1 week post-op. In a lot of them, we don't in our office just because of how it's set up with surgery.
Yeah.
And I think, another big part of that 1 week has always been the let's double check, see what your prescription was, hey, we're aiming for this. How close were we at on the first eye to make an adjustment for the second eye?
Yeah.
If they aren't waiting a week or two in between the 2 eyes, you don't need to do that at that 1 week anyway.
Right.
So,
yeah.
Yeah.
All good points. A lot to consider. And, I think that question is still an important question. There are some other ways that we could frame future studies to maybe include more patients with, other competing medical diagnoses and see how that might influence their potential risk. But yeah, some things to think about. And thank you so much for your insights today, Dr. Fosso. And thank you for listening or watching, and we'll see you next time.